the rest and shelter of the night, for the health and food, for love and friends, for everyone and everything that God goodness sends. In Jesus Christ we pray, amen. So Dr. Andrew Shi is a emeritus professor of the Family and Community Medicine and Pediatrics at UNM Health Center, who for 30 years has founded and developed planning and research that has led to two-brain, two-generation model of primary care. He's also been recognized as a top doc by Albuquerque, the magazine, for many years. And as a community leader, he is recognized for his advocacy work serving on the Vision Council of the Mission of Families United Way of Central New Mexico. So I welcome Andrew, Dr. Shi, and this great talk your folks are going to hear. Thank you.
Thank you, John. And I so appreciate being invited to address this gathering. And thank you to all of you in the class who are there I in the classroom. Appreciate you being here. I will share my screen and move into the talk. Oh, good. And it works, and so all that's great. Thank you for the great introduction, John, and I'm glad to hear that you're doing well, and I hope everybody else is similarly staying very healthy. I want to just line out some important information. So the disclosure regarding contents. So discussion of family trauma is difficult and may cause audience stress. And so I want to urge you that if you feel overwhelmed or this is difficult, to please do those things that allow you to take care of yourself. No actual pictures are used in this presentation of our current patients or clients. At the end of this presentation, I hope that you will understand health risks for youth in New Mexico, the concepts of adverse childhood experiences, the connection of those experiences to health risk behaviors, details from a case study that illustrates what services the ADOBE program provides, and solutions to improve youth and family health. All right, so I'm going to take questions at the end, and I'll jump into it so we have time for those questions. So the state of adolescent health in 2022 looks like this. News reports that epidemic levels of anxiety and depression exist among youth and adolescents in the US. And it's been attributed to COVID-19 infections and the risk of infections and quarantine and remote school. Overlying that, New Mexico is ranked at the bottom of the US for child health indicators, currently 48th for family and community supports and 48th for economic well-being. By other national measures, New Mexico is 46th for total health outcomes for adolescents, and the leading causes of death for youth from 15 to 24 in New Mexico are tragically unintentional injuries, car and pedestrian accidents, overdoses, etc., suicide, and homicide. So the state of adolescent health in 2022 in our communities is something that provides great opportunities for work to improve things. Okay. Now, having said that, I want to talk about adverse childhood experiences because those things start health risks in adolescents that contribute to the leading causes of death and concerns around anxiety and depression. I would view this as the most important but little known health information that's been available to the US for over 20 years. It was published first in 1989, and its publication and the expanding knowledge should have transformed medicine. But I would say that there's been slow uptake for reasons that I will try to explain. The study started with looking at 17,000 people in Kaiser Healthcare in San Diego.
You don't want to start video.
That made me come up?
Yeah.
No?
Yes, I'm over here. See?
Oh shit.
That's what I was trying to get.
What is it? Oh, what is lead the meeting again?
Welcome. The average age of individuals who were studied were 56 years old. Of that group, 52% were women and 79% were of European American ancestry. So this is a population that is very typical, was typical of San Diego County. And people seeking healthcare, 2/3 had graduated from high school and 1/3 graduated from college. So this was also highly educated, economically secure community. The research found that 62% of adults had at least one adverse childhood experience, which we will now abbreviate as ACE. And in the US population studies that have been done since, more than 60% of people in those studies, now numbering over 200,000 people, more than 60% have had at least one adverse childhood experience. So I want to point out that this finding affects the majority of people in the US. And interestingly, I would say that overall medicine is really directed at the 40% or so who've not had adverse childhood experiences. The definition of those experiences are the following: emotional abuse, emotional neglect, physical abuse, and sexual abuse of children under 18, most of which occurs in their family of origin. These are individually experienced traumas that have lifetime potential consequences. In addition, there are 5 others, and those include the mother in the home treated violently, that there's household substance abuse by an adult member, household mental illness that's not treated, parental separation or divorce, or that a family member, adult in the family, is incarcerated. And so these 10 factors in the Kaiser study were highly associated with the long-term health outcomes and risks. Let me give you an example. The direct effects of children from caretaker abuse and neglect creates a risk of toxic stress, and the family, household dysfunctions and home environment can also create toxic stresses. And in the Kaiser study, what that led to was a finding of a relationship of numbers of adverse experiences displayed on the bottom of the graph, and then comparative relative risk. So let me explain that. For heart disease related to numbers of ACEs, if an individual had 0 adverse childhood experiences, so about 40%, 30-something percent, their relative risk for heart disease was set at 1. If the individual had 1 or 2, their relative risk for cardiac disease was 1.5. And you can see as you go out, increasing numbers of ACEs, at 5 to 6, the rates become almost 2. And at 7 or 8, the rate triples from having no adverse experiences. So heart disease is the leading cause of significant morbidity and death in the US population, and has been for 50 years. How about chronic lung disease or asthma? The same relationship holds true, that with no adverse experiences, the relative risk would be 1.3, meaning that there's some risk of asthma and chronic lung disease for the population. But as you expand out to, say, 4 adverse experiences, the rate is increased by almost 5 times and almost 10 times when you get to greater than 5. So the researchers at Kaiser found this unexpected relationship of the number of lifetime adverse experiences that an individual had experienced before 18 years of age was related to the risk of leading causes of morbidity and death in what would be viewed as a dose-response relationship. And a dose-response relationship in pharmacology could simply be explained that you expect a bigger effect with increasing doses of a medication up to the point that you reach toxicity or harmful effects. And in both of these leading causes of illness in the US, there's a dose relationship, a dose-response relationship. I mentioned mental health issues and depression. And so if we look at depression in the same population, and this on the left-hand side is percentages as opposed to relative risk, for a population with no adverse experiences, the relative risk for depression ranged between 10 to 15%. If that were expanded out to 4 more adverse experiences, the rate goes up to 40 to 60%, a 4 times increase in depression. Now, there are 2 bar graphs, and I would ask you all just to guess which bar, the taller or the shorter bar, represented females and males.
Females.
The larger bar would probably be females, and that's exactly right. So females in general have a higher rate of depression than males in the population. And if we look at suicide risks, the risk of suicide similarly increases in a dose response to the number of adverse experiences. Again, on the left side are percentages, and on the right are numbers of ACEs. Now, there are high-risk behaviors that lead to long-term poor health outcomes. And in the top bar graph, the relative risk for intravenous drug use, which is a huge concern in our community, related at least up until the advent of fentanyl arriving, to significant risk of overdose and death. And again, the relative risk for intravenous drug use with no adverse experiences is about 0.25. And if it goes out to 2 adverse experiences, the rate almost triples, and out at 4 or more increases by a factor of more than 7. In the second bar graph, the bar graphs represent, the smaller ones represent the individuals whose parents did not have an alcohol problem, and the longer bar graphs, those whose parents did have an alcohol issue. And you can see that, again, there is a dose response for the risk of long-term alcoholism based on the numbers of adverse experiences, but it's enhanced by the presence of a parent who had alcohol problems. And this is another numerical graph that I'm going to just skip because it basically says the same thing, and I think it's less visually appealing. So let me just go over that, get past this. Whoops, got all the animations. I'm going to jump into the case study of Marcy, who is representative of the types of individuals that we see in the ADOBE program. So Marcy is referred to the ADOBE program, and the ADOBE program is a program that is specifically designed for youth who are released from juvenile detention in Bernalillo County up until our funding ran out, probation conditions, community release conditions, and referred from CYFD. The patient population that was referred to ADOBE is 97% insured by Medicaid, had incomplete health care of various types, had underlying mental health conditions, something in the range of 96%, and substance use disorders, something in the range of 99%. The majority who were enrolled were not enrolled in school or not employed. And I would just want to mention that on average, when we looked at the presence of adverse child experiences in the group of young people released from the Bernalillo County Detention Center and who came to our clinic, 75% had 4 or more adverse experiences. And just by comparison, in the Kaiser study, the rate of people who had 4 or more adverse experiences was about 12%. So they had a 6 times greater underlying adverse childhood experience before they had been released. Now, this also leads me to talking about health disparities. And you've heard a lot probably in the media about health disparities, and what that means are that for different populations, there are different health courses over time. The types of disparities that are most prevalent in the US system are racial discrimination that has been historical, but it exists in the present, where health systems treat different races unequally. Differences related to being poor versus financially stable in health outcomes. Individuals who are gender diverse have a different health outcome, and stigmatized groups. For example, individuals who use substances have different health outcomes. And that is even for conditions not related to substance use. Youth in the criminal justice system have multiple disparities. So all of the above factors that I've listed, in addition to disparities in justice outcomes and educational disparities. So ADOBE as a program stands for this. It's an acronym for Avoiding Disparities in Outcomes by Building Engagement. And I'll explain here in the next few slides about how that looks in terms of engagement and how we think about trying to address the issues of disparities and ACEs. So going back to our case study, Marcy, who's 16, comes to the ADOBE clinic for the first time. She'd been released from detention after 15 days. The clinic was recommended by her probation officer. She comes to clinic with her aunt, where she lives with her younger sister. She'd been couch surfing before detention and living in shelters. And her mother, Cheryl, is not around. She's on the streets, according to Marcy and the aunt. In a confidential interview, Marcy has concerns about a sexually transmitted infection. She has a steady boyfriend. She and as a result of the clinic visit, where we are wanting to address the risk of ongoing infection, she who comes to clinic receives a prescription for antibiotics, and a prescription is written and sent for her boyfriend. So our goal is to make sure that we treat both partners and that we address their health risks as thoroughly as possible. And Marcy agreed to come back in 2 weeks to make sure that things are still going. Beyond that, Marcy is not particularly interested or willing to address other issues in the current visit. And for that moment, that's fine, because our goal is to begin to build a pattern of care to engage. And that's a critical part of our effort. So what makes Marcy have high risk for future detention? And I want to talk about a concept that's been talked a lot about in the media in the criminal justice system about the revolving door. The revolving door, as it's being described, is that somebody who commits a crime is released before there is sentencing or a court hearing, and then they go on and commit another crime, and they commit another crime. And we're hearing this talk in the law enforcement side about getting tougher on crime. Well, I want to change that just a little bit to talk about the impact of adverse experiences on an individual like Marcy, who might in fact, get into the revolving door. So her aunt reports that Marcy and her sister's dad is in prison. Her mom, Cheryl's, had a pill and alcohol problem. The mom has neglected both girls. So if we go back to the original definition of adverse child experiences, Marcy has, at 16, has accumulated 3 adverse experiences. In addition, she has run away from her aunt's home. She has dropped out. She has a boyfriend who may be using drugs, and Marcy has tried to find Cheryl to help her. Now, Marcy, in her own desperate situation, couch surfing and living in shelters, is still very concerned about her mom, Cheryl. And we see this happening often, where the young person is as concerned about the parent or parents as the individual is about herself. A month later, Cheryl, the mom, drops into clinic with Marcy without really an appointment to talk. And in our clinic system and the way we manage this is our response to this, of course, we'll make time to talk to you. And Cheryl wants to know about buprenorphine, which is a replacement medication for opioid substance use disorder. And she says that she's tired of using oxycodone all the time. And you know, we are very interested in talking to her about that, because we're concerned that her substance use and use of oxycodone is driving the risk of neglect of Marcy and her sister. So if we can get help for Cheryl, we may be able to stop a pattern of revolving door experiences of substance use disorder and then getting off drugs and then relapsing and trying to enter treatment and then having a relapse again for Cheryl, and we may be able to stabilize things for Marcy. So I want to talk about the impact of ADOBE just a bit, having explained what we do and how we think about engagement with family systems. We started in 2017. We started with funding from Bernalillo County to do wraparound services for youth related from the Bernalillo County Detention Center. And the funding that funded ADOBE came from county gross receipts taxes, some of that extra 0.5% that we are paying for property tax. The main effect of ADOBE was to try to reduce return to detention. And I want to say that the county folks in the detention center and CYFD, all very supportive of trying to make these efforts. So we were working with them and not in opposition to their goals. We averaged seeing 69 young people per month in 2018, 2019, and 87 per month in 2019 to 2020. And that's the last cumulative data I have at this point. Bernalillo County had reported that there was a 70% risk of return to incarceration in the year following release for any given kid. And nationally, that rate's closer to 55%. After 2 years of doing our work in ADOBE, the rate of return for the youth that we could determine was 21%. So we'd reduced the rate of return to about twice that of the national, by half that of the national average, and almost 2.5 times that of Bernalillo County, with what we think of as the possibility of interrupting the revolving door of being arrested and put in detention and released, and then being arrested and put in detention again. So we wanted to try to get into how to improve overall health. And as my friend and colleague, George Davis, who's a retired child psychiatrist and who helped start the ADOBE program, said, not returning to jail is just the first step of many. So the goals of ADOBE go beyond that of trying to keep kids out of detention, but beginning to think about what life looks like moving forward. So who's been concerned about crime? I know I have, both in the large sense and the small sense. And this is that revolving door that we talked about, right? And then the real question is not that we observe that there's a revolving door, that people who've been incarcerated have a greater risk of being incarcerated again, but we start thinking about what allows a person to get out of the door in the first place, what allows things to happen so they don't keep going through that door. So this is what ADOBE provides to Marcy, her aunt, and Marcy's sister. And I've conceptualized ADOBE as a four-legged stool. One of the legs is navigation. Another is educational support. A third is medical support, and a fourth is legal. And the navigation, medical, and legal sides work to stabilize young people and their families sort of as soon as possible. And the educational piece is, in a sense, the future direction. That is what we hope to optimize as a result of our efforts. So what the navigator, the home community-based navigator assigned to Marcy, does is intensive case management and assist the family, including Cheryl, who's not even living with Marcy, with benefits. Frequent contact, checking in with the family, and helps with job readiness for the aunt and Cheryl, even though Marcy is our primary client, because it doesn't make sense if we only concentrate on Marcy without looking at the aunt and Cheryl. How do we try to achieve financial stability for the family? The educational navigator assigned to Marcy and her sister, especially in the pandemic world, has assisted with acquiring devices for virtual learning. So it's super that APS, for example, has supplied devices to Google Chromebooks for kids to do virtual school. But there's some families for whom even the transportation issues of getting the Chromebooks are difficult, or who have not been, for example, really going to school to then enroll and then get devices. And they are also working to ensure that sisters are in the correct programming and helping schools follow the IEP, which is the individualized education plans that are developed for kids who have special ed needs, and the behavioral intervention plans that are involved with kids who have a history of behavioral problems that have caused problems for the school. We have primary medical care for Marcy's family. So I mentioned the mom, the sister, Marcy, and we would even offer primary care to the aunt if she did not have primary care, because our goal is to try to do things that allow the whole family system to be healthy. We have clinics in North Valley and Southeast Heights family medicine clinics. And during the pandemic, many of those visits had been virtual. We're now in the sort of mixed virtual hybrid model. The full scope of child and adult primary care is delivered in ADOBE clinics, and we help Marcy catch up on immunizations so she can attend schools. We have organized opioid replacement therapy for Cheryl so that we can stabilize her, and that allows us to have contact with her very frequently. We also organize adult preventive care, which would include things, for example, like helping schedule a mammogram for Cheryl to make sure that we can prevent the onset of undetected breast cancer, getting dental care organized so that her poor dentition can be cared for. And then very importantly, and I'm so honored to have Dr. Boss with us this morning, is that we organize psychiatric and mental health care for Marcy's family. And so in our clinics, in addition to having primary medical, we have psychiatric care in clinics at the same time. So in any given family, for example, Marcy and Cheryl, if they came into clinic for a medical visit and there was a psychiatric potential crisis, our psychiatry team, like Dr. Boss, will step in and have contact with the family right there on the spot. And it's such a different kind of world model than what has currently happened in primary care, where trying to get somebody to mental health or psychiatric care is quite a difficult effort, and it occurs in a different location. So we can provide almost immediate relief for some of the potential psychiatric crises that might happen. And this is especially important given that there are increasing rates of anxiety and depression that have been going on among youth. The ADOBE Clinic provides legal referrals to UNM Law Clinic so that the law clinic can assist with civil legal issues. A law student will meet the family and then present the legal issues to a faculty member. This could include custody concerns. So Cheryl fortunately agrees that the girls should live with their aunt while she's getting stabilized, but she has landlord issues in terms of where she's living. And so the legal team can help with that. And we often get involved in immigration issues. The clinical law students, they're third-year law students, represent the client. They have faculty supervision to represent and to present to. And pre-pandemic, the law students were able to actually go and meet the clients in their homes or in the community, which again is a very large departure from the current system where clients are expected to show up at law offices to get help. And for some families, the issues of time, money, and transportation become insurmountable. If families are living on a very limited budget, they have to make decisions about whether to buy food or buy gas, whether to buy medications or buy gas to go to appointments. And the balance of that is just very challenging. So interim outcomes beyond that of not returning to jail would be the qualitative observed improvements from Marcy. So having consistent contact with navigators, and we find that consistent contact is related to the greater likelihood of stabilization. There's stabilization in family contacts. So the reestablishing relationship between Marcy and her sister and Cheryl is another qualitative improvement. Marcy's able to address her probation terms. She completes the terms so that she's no longer under probation supervision. There's appropriate utilization of the UNM legal team to address legal crises. Marcy and her family members return calls and texts with the navigators, and they come to appointments. And one of the things that we found during the pandemic is that the ability to deliver virtual mental health psychiatric visits has been significant, and that many young people and families have sustained their contact with the psychiatric team. Now, to be real honest, the longer the pandemic drags on, the harder it is for everybody to sustain energy. And so, it's not a perfect system, but it certainly is, at least in my view, a significant effort on our team's part to try to sustain engagement to continue to manage care. There's some qualitative observed barriers for Marcy. There's unstable housing and rent issues for her aunt, and especially because her aunt has housing, but it wasn't really set up to accommodate 2 additional youth in the home. There's limited access to communication because their cell phone bills are often too expensive for them to have direct communication. It's fortunate that the Google Chromebooks can actually, if they have internet connection, help with virtual visits. And then there's school barriers. And I mentioned at the beginning of talk issues of educational barriers. Well, only a limited number of schools will engage with Marcy. A number of schools in our community do not really want to help a young person who's come out of incarceration, who's kind of has transient housing, get enrolled in their school. And so the education specialists have to work extra hard to find the right setting for Marcy to go to school. So what does it mean to reduce recidivism? So recidivism is that sort of golden concept that's out there, the idea of having young people so they don't return to jail. Well, when 80% of the youth engaged with the ADOBE team do not return to incarceration, it means that there's reduced contact with the police. So given all the things we've heard about the risk of violence to police officers, but also risk of violence to individuals confronting the police, reduced contact is a good thing. There's stabilization of living conditions and home life. There's reduced costs to the county for detention costs. And detention costs on average run about $170 per day, if not more. And the average length of stay is about 17 days. There's reduced court, CYFD, and probation costs. There's access to basic needs, often food, so that the family's ability to sustain themselves is improved. There's a start on educational pathways with a future view of what the young person might be able to do in their life. There's stabilization of mental health, and there's a role for medicine in stabilizing mental health, and that in primary care. What primary care doctors can do is play an active role in supporting the access to psychiatric medication. In addition, the opioid replacement medications for something like oxycodone, substance use disorder, and there's more frequent contact with healthcare, which is really important in terms of the ongoing disclosure of potential chronic health problems over time, that, as we showed in the first slides, in the risk of having those diseases become life-threatening increase with an increasing number of ACEs. And so in the medical sense, if we can see our patients more often and the more carefully and thoroughly address those risks, we can potentially reduce the long-term health outcomes, poor health outcomes. In my view now, reducing recidivism means helping whole families reduce or prevent ACEs. So it's not just directed at the young person who's our primary referral, but the whole family system. So I mentioned adolescents have experienced ACEs, and that 75% of the young people we meet have had 4 or more. Their future health, social, and education, the likelihood of achieving those goals means that they have no more ACEs occurring in their life. We understand that ACEs start in family systems, that parental mental illness doesn't need to be stigmatized. It needs treatment and support. That parental substance use disorder needs treatment and not exclusion, and that parental housing and job instability needs stabilization. And the more those things are likely to happen, the greater likelihood there is for the parent to begin to take an active role in their kid's life and do the things that help the kids go to school, for example, to make medical appointments. And the completion of school equals very different futures for kids. We know that a person in the US who has completed high school education has a much different health outcome than somebody who's dropped out of high school. And so what we've seen in ADOBE is the ability to help a number of young people complete high school requirements, graduate with a degree, and we've seen some of them enroll in UNM and some of them enroll in CNM, which is incredibly exciting to understand what can happen when things stabilize. So teens and health, going back to the condition in 2022, what COVID has shown us is that there are increased disparities about what families, what individuals have to work on site. So there's disparities in who gets to work remotely and who has to work on site, that those who work on site, for example, in the service industry, have increased risks of illness. There's decreased access to immediate health care because of pandemic conditions. And there's, more importantly, decreased access to behavioral health services. And because kids are home with their families, I think the families have become more aware of behavioral health problems that in the past might have only been apparent to the schools the kids attend. When the Surgeon General talks about protecting children's mental health, to us that means greater access to services, including potentially school health and in primary care clinics, that we help parents resolve their own behavioral health issues that contribute to the risk of anxiety and depression for young kids, and that there's system changes made to reduce and prevent ACEs. What can we do? Well, one of the things that we can do is talk about in our institutions, talk about ACEs, to begin to make explicit the understanding that 6 out of 10 people in the US have had at least one experience, and that 1 in 8 have had 4 or more. Because I think that the more that stays out of the picture, the less likely it is that we're able to begin to offer the appropriate supports and to modify systems to reduce the impact. We can advocate for children and families with potential mental health issues as opposed to shunning them or discriminating against them. And that care needs to happen before kids have contact with the justice system. And so, for example, we're interested in supporting Marcy's sister and helping her with potential mental health issues before her behavior escalates to the point that she becomes a ward of the state. And we need to think about knocking down behavioral health system barriers, whether that's funding or scheduling or location of services or discrimination of all types. For the near future, there needs to be integrated behavioral health models of care. It's a critical need now, and it needs to be integrated with thorough primary care. Well, that means that you have to find behavioral health providers who are willing to communicate with primary care providers, but you also have to find primary care providers who are invested in delivering supports for behavioral health and psychiatric health care supports. That primary care particularly, but other specialists in general, cannot say, well, I don't want to address the patient's depression, or I don't want to get involved with a patient who has substance use disorder because it's just not convenient for me. Those barriers have to be knocked down, and that's discrimination that exists within health systems and within the financing and planning of health systems. There needs to be increased access to telehealth services, and supplying tablets for remote learning is one part of that. Even when kids should be in school, there are going to be kids who, for various reasons, they're being bullied at school, they're really depressed, who would do better if they could access online learning. There needs to be distance models for behavioral health. And New Mexico has taken steps to increase the fiber optic network to improve internet access, but part of that should be coupled with the understanding that increased internet access does not mean more downloads on Netflix, but means the possibility of providing health services directly to the home. It means that meaningful protection of children's mental health means preventing ACEs. That if we want to help kids not have escalating mental health issues, that intervening in the issue of ACEs, preventing them in family systems is critical. And finally, of course, there's always a need for increased funding for integrated services. All right, so that's really the end of my presentation, and I'd be happy to take questions. And I'm going to get out of my sharing here so that I can, yep, stop share. Okay, great, good. Thank you all for sticking with this presentation, and let me please know if you have questions.
Andy, the first question, since I got into the meeting a little late, is how is your mother doing?
Hi, Lane. We'll see that. They're on the screen.
Yes, I see them.
Yes. And well, I'll let them speak for themselves, but overall, I think they're doing great and getting ready to celebrate Chinese New Year's.
Oh, good.
It's good to see you, Lane.
Yeah, good to see you. Good to hear about your wonderful program.
Thank you.
One of the questions I had for you, Andy, is what is the current status of the program?
Yeah, great. Lane, at this point, we have had support from a couple of state agencies to sustain us through this year. So the Public Education Department and now the Behavioral Health Services Division have committed to funding our team. And that's primarily the navigators and the education liaisons and our administration evaluation team through June of 2022 and perhaps longer. And we are morphing into a behavioral health service providing agency and will begin to access the expanded CC Community Care Coordinated Services funding through Medicaid to begin to try to build sustaining funds. So at this point, I'm happy to report that we are in pretty stable shape with the possibility of expanding services to beyond Bernalillo County, since the funding comes from the state, and to begin to touch on kids who live in Sandoval and Valencia counties.
And what does that take in terms of both staff and how many clients do you have at any given time?
Yeah, thanks. So before the pandemic hit and we were seeing people all the time in clinic, we were averaging about 150 to 170 young people per year, which meant generally another 1.5 individuals in the family who we were also supporting. So that number probably was closer to 300 people. Since the pandemic, and now in sort of the third year of the pandemic, it's hard to get an exact count because we have, families have challenges in terms of maintaining things like cell phone service. But if we look at our appointment list and who's scheduling, I would say that we're currently following between 40 and 50 young people on a regular basis with 1 to 3 new referrals per week coming from the detention center or CYFD or other sources. So fewer, but still a substantial number. You asked about staff. Our current staffing is, we have 3 full-time navigators, and we have 2 full-time educational liaisons, 1 social worker, 1 program director, and a scheduling assistant who her work basically is the front interface for all family contact. And you can think of her like air traffic control at an airport, where she's handling like 30, 40, 50 calls a day, trying to make sure that families and their appointment systems get connected. And then beyond that, then our team includes family nurse practitioner, pediatric faculty, psychiatry faculty, a psychiatric nurse practitioner, but the medical team is not funded out of program funds, except for a small part related to our research responsibilities, and are funded through normal billing systems in the medical system. And I am happily an emeritus person who is not funded under any of our program funds because I'm sort of an expensive fossil. So the working members of the team are those who are funded.
Sounds like a great program. It really does. I kind of thought that sort of thing needs to happen. And it seems like everything gets piled into the school, which is a great contact point, but they're so overloaded with everything that we've laid on them since 1960 or whatever. I don't know. It's no longer just teaching. It's social work and whatever. It's beyond their scope.
I agree with you completely. And when our education specialists go to schools with young people, what we found is that we can alleviate so much of classroom teachers' concerns and anxieties about, for example, do kids have chronic, ongoing medical care? Do people hear the teachers when they say, I'm concerned about this kid hallucinating and can you help? Because we can get them in to get evaluated so that the teachers are not carrying that emotional burden by themselves. It's taken a while, but we're building trust with administrators in a number of high schools and teachers and police officers in the schools. And so over time, I think that they appreciate the fact that there's another set of people who are involved with the child and family who have active participation.
Sure.
Andy, if you could, if money wasn't an issue, what other things would you want to include in the program, or what parts of the program would you want to strengthen or increase your personnel?
Yeah, Lane, thank you. Well, I mean, the first thing I think is most important is that we figure out how to improve the possibility of telehealth communications with families. So, for example, one of our proposals has been to fund devices for which we pay the data charges and communications, and we take those devices to kids and families so that they don't have to pay the phone bill in order to be able to communicate with our navigation, education, and medical teams. So we can knock down that barrier by pretty simply funding the devices. A second piece of that is to have the increased in behavioral health potential in our program, because what we found, the amazing part of work is having a psychiatrist like Dr. Boss, and before that, George Davis in clinic, and be able to say, I'm worried about this kid, and what do you think? And am I on the right track, or what do we need to do? Or vice versa, to have the psychiatric team say, I'm concerned this kid has a medical issue affecting their sleep, and can you do things to help them? And so to have a behavioral health person say, this young person may have cognitive delays that we haven't detected previously that we need to get testing for, or I'm providing counseling for individual family members in addition to their medical stuff, coordinated with psychiatric med management. That, I think, would be the future of integrated services. And then lastly, I mean, if I were going to, say, okay, you could have limited funding, it would be that we could begin to address the discharge issues of kids released from the state youth prison in 4 or 5 different locations in the state, so that these young people who have had long-term or prison sentences, for example, when they are released, have the kinds of coordinated services so that in their communities, so that they were not at risk of entering the adult prison system.
Andy, is there a equivalent operation like you in other areas in the United States? Or are you just a key factor and it needs to expand?
We're, as far as I know, pretty unusual. In my context, national level with other pediatricians or primary care doctors, they have not been able to build the kinds of model services that we've built in New Mexico, in Bernalillo County. And so we've been asked to consult with, for example, a group in Omaha, Nebraska, at the University of New Mexico, University of Nebraska Medical Center. But I have not found other places that have been able to achieve what we've achieved. We would love to have peers and colleagues with whom we could, understand what worked and didn't work for them, so that we wouldn't repeat similar mistakes. But we just haven't found that yet.
So could you explain what you meant by two generations model of primary care?
Oh, sure.
Yeah.
Yeah. So, when I think about, okay, let's just take any parent whose child has a major mental health issue, even without other underlying adverse experiences in the home. What I found in my private practice, those families are struggling to find the right services for their kid. And yet, even when that happens and their child is beginning to receive the appropriate psychiatric or behavioral health services, the parents are grieving. They're going through tremendous emotional stress and grief, and often they have no outlet for it. Their primary care person often is not really able to hear about it. So even in families that don't have all the other adversities that we've talked about, the ability to be able to reach out and say, hey, how you doing? And would you want to come in and talk about potential depression and ways that we might be able to help, would be of great benefit. For the families that we take care of who have various risk factors going on, what we understand is that they're in a developmental phase of their life, that they are developing the kinds of skills and hopefully resilience capacities to stabilize. And just as their young person is also in a brain development phase and trying to grow into adulthood. And so if we can, as a program, help both the parent and the child in terms of their brain development and increased capacity to develop skills, then we have a much better chance of helping the entire family system become socially and economically viable.
Thank you.
Andy, a question about the detention facilities that these children are in. How much education do you do with the people who work in them? How receptive are they to what you're doing? How integrated is the work with them at this present time?
So the administration of the detention center and CYFD probation and parole have been key partners for us. They have been very committed to how we're trying to do things. And I would say that unlike many jail and detention systems, if they could reduce their population from Bernalillo County to 0 and not have to put any kid into detention, they would be fine with that. So I think that's a real interesting perspective that they have compared to other systems that really are trying to, maintain employment systems for the detention workers. Medical care has been interestingly more difficult to integrate than we would have thought. We don't have, other than, for example, our psychiatry team reaching out to the psychiatrist who provides care in the detention center, or directly reaching out, kind of personal phone call or email to the physicians. We don't have a great way of tracking what's going on with the care provided in the detention center and how we then need to plan on providing care. Lane, these different systems are quite, I don't know, well defended. Even trying to get a med list for the kid who's been in detention, so we know where we're starting from, is an incredible challenge. And the same thing for RTCs, trying to get medical records from RTCs so that when a kid's discharged, we know how to understand their psychiatric care has been challenging. And it doesn't seem like it has to be. But in terms of the county folks, they have been, I think they share a philosophy about trying to reduce the risk to kids of entering the adult correction system if we can intervene now.
I think we're about ready, might be running out of time, right, Nicole?
Yes.
Okay.
Well, I would just like to thank you, Andy, for the good work you've done in this program and the other ones you've worked with.
Yeah, I agree
Appreciate
with
it.
Yeah, I agree with Lane. This is just outstanding work.
Thank you so much. And
Yeah.
I feel incredibly grateful to talk about our program in the context of the team who is continuing to work really hard and adapt to changing pandemic conditions and all the financial challenges and all. I mean, that's beyond the incredibly challenging, difficult clinical situations that we're trying to help. So I'm extraordinarily grateful to be a part of that group and to be able to represent the work. And thank you to all for being part of this conversation and lecture.
Yes, thank you.
Thank you very much.
Right.